Hello, everybody. My name is Eric Tridas. I am a developmental and behavioral pediatrician, past president of the International Dyslexia Association, and a representative of IDA to the National Joint Committee on Learning Disabilities. Today, we'll be talking about executive function, ADHD, anxiety, and I'll include a little bit of reading in the process. So let's begin with our presentation. First thing, as a developmental pediatrician, one of the things that I emphasize is that children are not born with the executive function skills. They are born with the ability or potential to develop them. And just to have a very brief review of what these skills are is what allows our students to organize and integrate rapidly changing information, like what's happening in the classroom, to give the top of the mountain perspective. We hear the analogies of the general in the battle or the air traffic controller, the orchestra conductor. But getting that big picture of where things fit is very important. And he does it by integrating multiple sub-skills while shifting from the big themes to the details that are necessary. And it will affect a lot of functions like accuracy and efficiency, note-taking, getting started with projects or activities, planning and executing long-term projects, submitting work on time, sustaining attention, and the behavioral and emotional regulation that we expect of the children. What we know is that these skills develop with the interaction between the child and the environment. Like many other neurodevelopmental functions, the ability to develop these skills, it relates to not only our genetic predisposition, but environmental factors and ways in which things are taught or encouraged. And that shapes our neuroanatomy and our functioning. It's the same thing with ADHD, it's the same thing with reading problems and other factors. It requires flexibility to focus our attention on specific sensory input that is coming in. And that sensory input is processed in our brains, and it reaches out to our memory and all of the other previously learned skills to put it into context. So there's a bidirectional interaction between these control systems and the functions they're controlled. That's why context is so important, like how do I speak to someone like a school principal versus how do I speak to my friends? An important concept to understand is that executive functions are more of a resource than a discrete function. It's the how we do things, what do we use these skills for, rather than what they are per se. Now, these skills improve in two ways, or they're developed in two ways. First is by experimentation. Play is a wonderful way for kids to develop executive functions because they encounter problems and they solve them and they figure out what worked the best. The same thing happens in social situations. The second one is by external cues or limits or scripts. I mean, those of you who have children, how many times have you channeled your parents and your grandparents and your relatives through your body when you're talking to your kids? Because that's how we regulate the behavior. All of those things that we learned in infancy, that were in childhood, that were drilled and re-drilled in our brains, come and affect our thinking. And that's how we do it. So this leads to self-regulation of learning and behavior, which are the two main strands of executive functions. I love this graph because it shows how we develop executive functions, and what we see is that between 4 and 5 years of age, we see a dramatic increase in executive functions. Again, those of you who have children, you know that when the kids turn 4, it's like a magical moment. You can take your eyes off of them for at least 30 seconds, and they may still be in the same place. We also know that our insurance rates start to go up when driving at the age of 25, because by then we begin to see significant maturation. So after that, unfortunately, we begin to see a gradual decline of these skills. What are three processes that we focus on that affect executive functions? Well, first one is inhibition that leads to self-control, cognitive flexibility or shift, and working memory. These are critical skills that we have to have in order to control our in order to control executive functions. What is inhibition? Is our ability to wait, to stop, to delay a response, to put a space between thought and action. And that leads to us figuring out maybe what would happen if I do this, or to setting goals, to formulate a plan before attacking a project. And it also impacts time concepts. So it's very important. It allows us to be reflective and is what leads to impulse control. Very, very important. On the other hand, shift or cognitive flexibility is our ability to revise or change strategies or plans when the conditions change. It's a new way of doing familiar tasks or making a different choice when the first one was not available, tolerating changes in our routine. Again, any of you who have dealt with children with autism spectrum disorder know that cognitive rigidity is a major problem for them. These kids drive a train, they don't drive a car. And if you force them to switch tracks and to change tracks and there's not a switch in the tracks, then it leads to derailment. And that's how critical cognitive flexibility is, because we must be able to adapt to new situations. It's what allows us to adapt and grow and develop multiple strategies to manage different situations. It allows us to shift attention. Another important thing, that's part of selectivity. What are we going to focus on? And transitioning to move from one activity to another without wigging out. Finally, we look at working memory. And working memory is like the RAM of our brains, is the platform where we think and collect information, bring sensory input, and process it into understandable information related to previously learned material, and then lay out a plan of what we're going to do with that information. So it allows us to temporarily storage, integrate, process, and dispose of information while retrieving information that allows us to use it within the context of the real situation, of the moment. It requires active monitoring and or manipulation of information or behaviors, and this usually happens in the face of distractions. So in a classroom, for example, when you're sitting listening to a lecture, there's multiple sensory inputs coming, from the pressure of the chair on your bottom to the proprioceptive message being sent by your hand if you're taking notes or typing, to what the other kids are saying, or to what you're going to be doing at the end of the day. Yet we still need to focus on what's going on. So that active monitoring and manipulation is very, very important. That's that selectivity again. Working memory has a very small storage capacity and short duration. It can only hold about 4 to 7 items at a time, manipulates them, dispose them, and we go to the next thing. It is a complex process because it involves it's sort of an auditory component, which includes phonological storage, which are the sounds of speech that are stored in the sequence, and the articulatory rehearsal, which is kind of like a loop that repeats them. If you are old enough to remember when cell phones first came out and you would call directory assistants, they would give you a number, and you had to remember that number while dialing it at the same time. For me, that was very difficult. Then we have the visual component, which deals with the visual spatial sketchpad. We have a visual subsystem that deals with shape, color, and texture. So, is it a B or a P or a Q or a D or whatever, where the little ball sits in reference to the stick that makes the letter. And then the spatial subsystem, which is the sequence with which those symbols present. And And then there's a third component, the episodic buffer, which integrates the two of them and puts them almost like a video in a sequence. And all three of those are controlled by the central executive. So it's almost like a mini executive function channel that we have in there. So in the context of that information, let's see how this would impact reading. If we focus on the simple view of reading, we know that decoding times our listening comprehension will lead to reading comprehension. Decoding and fluency, very important skills. With the new definition of dyslexia, we know that not only need to focus on phonological processing, but also the speed with which we decode those single words. And these are acquired or learned skills. We need to go to school to learn this. It doesn't happen naturally. The second component is our listening comprehension or language skills. If I don't understand what I hear, I won't be able to understand what I read. So language development is critical here. At the word reading level, we know that we have the phonic component, that's the deciphering of these skills, which requires phonological skill and letter sound knowledge. While at the word level, we need that sight word memory, that orthographic knowledge, and the phonological long-term memory. So it links what we know in terms of recognizing a word to the sounds that combine into a word. When we get to language comprehension, however, we need to have our intact language skills, which will require things like syntactic and grammatical knowledge and vocabulary and inferencing and extrapolation, those metalinguistic skills that are so critical for us in learning, the ability to understand what the author meant by what he wrote or what the person meant by what they said. Then the background knowledge. Again, many of you are very familiar with executive functions and with learning and with attention and all of that. So you can fit the information that I'm giving you because of your general knowledge and also your topical knowledge of the subject. And it depends also on the genre and the text structure. It's very different to read a novel than to read a textbook, for example. Finally, we look at executive functions, and here it's very critical that comprehension monitoring. What am I reading now, and how does that relate to what I learned before? I'm also have to pay attention to the details to recognize what's salient and important. And all of this is done in my working memory. So really reading and writing and math and many other skills are intimately related to our executive functions and to our issues with attention. So let's talk a little bit about attention. Let's talk about ADHD. What are the core symptoms of an attention deficit hyperactivity disorder? They are inattention, impulsivity, and hyperactivity. What is inattention? Is the inability to regulate focus. That means it doesn't mean that these kids cannot pay attention. It's that they cannot pay attention to the right thing. That's our selectivity. At the right time, our timing. Am I listening to the teacher when she's giving instructions or when she's talking to someone in the hallway? For as long as it needed, did I hear the instructions from the beginning to the end? And with it's enough depth as needed to comprehend the matter, as we saw in attention for reading comprehension, for example. So it's the control and regulation of the function of attention rather than the presence or the absence of attention. Impulsivity, our inability to sustain inhibition. Again, that inhibition that we described previously, the ability to stop and think about the consequences of our actions, to stop and formulate a plan, to think about previous experiences or rules. You know, how often do we see these kids that make the same mistake over and over and over again? I mean, the parents constantly, we hear, how many times do I have to tell you? So we see that because they never stop to think about what happened previously. And they have difficulty blocking away distractions. Again, inhibition requires us to block away distractions, which impacts our selectivity. Finally, we also look at waiting for questions to be finished or waiting for your turn, which will have a significant impact in your social interaction because you're interrupting all the time, because you provide either a partial answer or the wrong answer because you responded to something that you thought the teacher wanted to ask you. Next, we have hyperactivity, and we have three types of hyperactivity. We have the overactive child, and this is very easy to see because a kid can stay seated, they run rather than walk, they're driven by a motor. We can diagnose these kids from an airplane, They're fidgety, they can't sit still, or they talk too much. So we classify them as motor feet, motor butt, and motor mouth. And those are the core symptoms of hyperactivity. And you can have them presenting in multiple different ways. So what would be the clinical impact of ADHD? Well, we measure clinical impact related to work, which in the kids' case is school, behavioral and emotional regulation, social relationships, and health. So academically, we see lower productivity and accuracy of work. Why? Because if you don't stay on task, you don't finish your work. You take longer to complete it. If you don't pay close attention, self-monitoring to what you're doing, you're going to make careless mistakes. So it's not that they don't know how to do the work, it's how they do the work that is affected. Remember, attention is part of what we control with our executive functions, and that's the how, not the what. Behavioral and emotional regulation. These children tend to be non-compliant, different from defiance. A non-compliant child, you tell them, go get me a glass of water, and the kid walked into the kitchen, and the dog came in, and they got sidetracked, and they never got you the glass of water. They did not defy you. They just kind of forgot, life got in the way. The defiant child heard you, thought about it, and said, no, I'm not going to do it, and you can make me. Those are very, very different. And because they're intrusive, because they're impulsive, because they talk too much, because they run about, they tend to be disruptive. And that will have a significant impact, particularly with social interaction, because the parents of the other kids don't want them around because these kids are too disruptive. The other kids get fed up with the kids too, because they don't read social cues very well, because they're not attuned to them, because they don't wait for their turn, because they want to call the shots even though they don't know what the shots are. And when they start losing, they want to change them again. And finally, we have health problems associated with ADHD. We see increasing accidents, increasing substance use disorders. So it's significant. ADHD individuals get more traffic tickets than people that do not have ADHD. So if we were to look at the life of a kid with ADHD, let's say an elementary school kid, what would we see? Well, before school starts, waking up in the morning may be difficult because it took him a long time to fall asleep at night. Getting ready for school requires an act of Congress, someone on top of them. You send them to get dressed and the hallway get on the way. They started brushing their teeth and you go in and the toothpaste is on the toothbrush and they're making faces at the mirror and laughing at themselves. They need for constant redirection. And as part of the process, they may be arguing with their siblings if there's some in the household. And you get to school, and transitioning into the classroom could be a problem because they never know where they have to put things. They have poor work completion, careless errors, lack of focus, disruptive, and they may have peer problems. So the teachers are complaining about the kid very frequently. Then we get home, and homework is a nightmare. It takes forever to be done. And after they do it and torture those poor parents for hours getting the homework done, they forget to turn it in the next day. They may be disruptive in sports activities or clubs that they participate in. When they get older, there will be more high-risk behavior. They don't sit still through dinner. They have to be reminded to use the napkin, etc. And again, arguing with siblings. And finally, when we get to bedtime, it's important to look at bedtime routine. How long does it take them to settle down? Do they follow the routine appropriately? Can they fall and stay asleep appropriately? Remember, if a child has significant sleep difficulties, we cannot talk about ADHD until we make sure that the kid has slept well at night. Because an essential element for attention is to be sufficiently alert to be able to pay attention. So that's important. Things like snoring may indicate sleep apnea. If we have a child that has severe nightmares or that has trouble staying asleep or trouble falling asleep. There may be an anxiety component associated with ADHD that could exacerbate the clinical symptoms. So those are things that we need to be looking at, because we cannot assess attention until we make sure that that child can sleep well. And that's how reviewing a typical daily routine with a child that you're suspecting that has ADHD can give you a ton of information, not only about the child's impairment throughout the day, but also about the family dynamics and the structure of the home. So let's look at ADHD and memory. If you think of the brain as a jar where we're going to bring sensory input in, and that sensory input is coming out of that faucet, we're going to go into short-term memory, and we'll break it into our verbal and nonverbal. Remember the phonological loop and the visual spatial sketchpad into working memory. And because we have to relate that to our long-term memory, we can get information relative to previously learned data or procedures. How do we do something? And that goes back and that determines what we do. But if we have an attention problem, we don't hold that jar steadily under that faucet. So I could have the most beautiful faucet in the world giving me a nice stream of water coming in, but if I have inattention, it moves. So sometimes the information gets in, sometimes it doesn't. Sometimes it's partial information. And that's what really impacts the kids, because they're so inconsistent that they pay dearly for doing it right once. And because everybody expects them to do it right every time. And the one consistent thing about kids with ADHD is that they're terribly inconsistent. So always remember that. Next, we look at anxiety. What is anxiety? Well, anxiety is what happens when the brain stays on high alert. It's expecting something bad to happen even when things are safe. There's a difference between fear, which is a response to an immediate threat. Okay, the dog is snarling and is ready to attack me and doesn't have a chain, or anxiety, which is anticipatory response to future or perceived threat. And I think that perceived is the most important word here, because it's a subjective feeling. It is not necessarily based in reality. And that's what defines it. The anxiety is a typical brain response. We need this. And that's what gives us the ability to fight, flight, or freeze. And freeze is probably the most common response that we see. We always talk about fight or flight, but we forget about freeze. The purpose of anxiety is to help us avoid danger. And that keeps us alive. Okay, so we see that there's a dangerous situation, we avoid it so that we will not get hurt. And it's present from the time when we're born till the time we die. But it will be present to different degrees. Like everything else, we have a continuum from mild to severe. So really, anxiety is adaptive. Okay, it facilitates avoidance of danger, which keeps us alive. It's not pathological unless it interferes with functioning. So when we have persistent or excessive degrees of anxiety, and remember that was that anticipatory fear, and avoidance associated with subjective or the perceived distress or impairment. So we're talking about the way that we're thinking about how we're feeling. Is that perception? And if we were to look at the manifestations or the symptoms of anxiety from the cognitive perspective, what we see is a constant frightening thoughts and scenarios. What if, misinterpretation of typical situations as a threat, or also in a panic attack. People think they're dying because they feel so terrible. There's an exaggeration of the probability of risk or threat. Okay, so again, these are subjective feelings. Over focusing on triggers of anxiety, which will then amplify the response. Well, what if this happens? What if this happens? What if this happens? It's really very important to recognize that, because these are thought processes and perceptions of situations that could be interpreted in a different way. It will have an impact on social interaction. The most common one is isolation and withdrawal. These kids tend to fade with the wallpaper because they don't want to draw attention to themselves, because they're very, very self-conscious. People they're looking at me eating, they want to see if I make a mistake or whatever. Again, that's a subjective, that perception that people are over focusing on them. At other times, it makes them have this need for control, because if they control the situation, then they don't have as much anxiety. So, oh no, we can't play that because, we can get hurt there, or that breaks the rules. And if I break the rules, I'm going to get in trouble, and that would be terrible. So it's like playing with your parents or your grandmother, which is not a lot of fun because you're constantly trying to protect you. Behaviorally and emotionally, fear is there. And remember that fear is immediate, but we also see anger and irritability. People that are chronically stressed become very angry. We see this a lot at home, because it's a safe environment. I call these kids my street angels and my house devils, because at school, that fear of getting into trouble makes them, behave so well and follow the rules to the T and all of that stuff. But as soon as they get home, they let loose because they have been holding all of this all day. And the mother asks them, "How was your day at school?" Or the father, and it's like the dam broke, and the kid starts yelling and screaming because you're constantly on my case or whatever, because home is the safe environment and they can act upon their fears. Avoidance of situations that trigger anxiety. This is important because, for example, if I have a reading problem and I'm anxious, every time I start reading, I may get nervous because I may not get it. So I avoid the situation. If I avoid the situation, I don't practice. And if I don't practice, I don't improve. We also see that in terms of social isolation, because people that have fear of in social interaction, they avoid it and they get worse and worse at it. The preference for familiarity and repetition, again, that intensified need of control. They want to be at home. The kids don't want to go on a sleepover or anything like that. And this constant fear, anger, irritability then impedes positive emotions like happiness and enthusiasm. And that's why anxiety is so often associated with depression, and they've developed that anhedonia. The lack of enjoyment of life is not that like life stinks, is that life has no smell. And that is a terrible situation. Finally, we have physiological responses. That includes somatization. And somatization is body symptoms. So the fast heart rate, the muscle tension, the dizziness, the shallow, rapid breathing, again, classical symptoms of a panic attack. And anybody that has had a panic attack will tell you they are convinced that they are dying. Again, a subjective perception of what's going on. And it's the scariest thing they have ever experienced. They sweat. They have trouble with sleep, so they may have trouble falling asleep because all of the worries of the day are coming in, or they wake up in the middle of the night. That happens to everybody, but in this case, it's just amplified, and they can stop thinking about different things that may be happening. Complain of a lot of different aches and, again, a lot of somatization. So if we look at the clinical impact and impairment associated with anxiety, academically, we see decreased productivity due to shutdown and avoidance. Again, avoidance lead to lack of practice, and lack of practice lead to a lack of proficiency. Decreased concentration. Why? Because my mind is consumed by my fears and my worries. So I'm not able to pay attention to the teacher because I'm so worried that something is going to happen. She's going to call on me. And that makes it very difficult. And this is an exhausting situation. So the kids have difficulty with mental effort. Behaviorally, low self-esteem. I'm the worst person in the world. It gives you, again, those unrealistic negative thoughts, and that makes you irritable and aggressive. And we see that at home. I mean, you may see tantrums that are horrendous in anxious kids, especially at home. We saw social interaction, isolation, withdrawal, and flexibility, and again, somatization, sleep disturbances, and a lot of these chronic stress factors or chronic anxiety factors. Stress is what life dishes at you. Anxiety is the perceived threat. May lead to substance use disorders and suicidality because it leads to depression, and people want to alleviate these symptoms any which way they can. So if we were to look again at anxiety and memory, what we see is when we have anxiety, all of a sudden everything breaks and it blows up. So as opposed to ADHD that is inconsistent, with anxiety, we just can't think. Our mind goes blank. That freeze response is because the system shuts down. We have different types of anxiety disorders, from phobias, which are, excessive fears like fear of bugs or fear of heights or whatever, to social anxiety. OCD is classified as a separate disorder, but the primary emotion in it is anxiety. An obsession is a thought that you put in your head that leads to a lot of anxiety. And then you're compelled to do things to alleviate that obsession, but it doesn't. We can have separation anxiety, panic attacks, and the generalized anxiety disorder, which is very common. Those are my words that will worry about absolutely everything if they can. So these are the things that we see. And you can see the relationship that exists between attention or inattention and anxiety and ADHD, and the control that executive functions exert on those functions, and how they get affected by these other disorders. So how do we put it all together? Now, I spent 37 and a half years in private practice evaluating children with different neurodevelopmental disorders, from infants that were NICU grads to adults, and disorders from cerebral palsy to ASD to intellectual disabilities and everything else. And the thing is, that is not that a diagnosis that we need to be looking at. Is we need to focus on those 4 areas of the quality of life. We need to look not only at where the problems are, but where the strengths and resilience of this kid are too, because it's your strengths and your resilience that are going to help you get ahead, and we need to capitalize on those. The 4 areas that we focus is work, behavior, social relationships, and health. I used to tell the parents of my patients, if your kid ain't doing bad in school, he ain't driving, you or the teacher's crazy. If your kid has at least one friend and he ain't sick or she ain't sick, life ain't bad. Anything above that is wonderful. Anything below that, we got a problem. And this is a clinical presentation. This is like a cake, and the cake is made of multiple ingredients. And while chocolate may be the primary flavor of that cake, it is not the only ingredient. So that's why focusing on one diagnosis is not appropriate. I think we need to look at what is impacting the child. Not only how are they doing in school, but what's happening with their behavior and emotional regulation, their social relationships, and their health, their sleep patterns, chronic health problems, all of those things. So there are 4 main ingredients to this cake that we call the clinical presentation. The first one is the child's developmental profile, and that includes attention and executive functions and visual, auditory and tactile kinesthetic processing. It deals with short-term working and long-term memory, and it deals with all of these executive functions that deal with the neurodevelopmental factors. It also deals with motor control. And if you think of the brain as a factory where you're going to put raw materials in, attention is going to play a role, processing speed is going to play a role, whether the task is sequential or simultaneous, whether the input is visual, auditory, or tactile kinesthetic, how good is your working memory, how well you can retrieve information from long-term memory, all of your executive functions that allow this to run efficiently. And then you either have to say it or write it. And your written expression is going to require fine motor control, is going to require a lot of grammatical knowledge and, spelling or orthographic knowledge, all of those things. We can also look at the behavior profile. What is our behavioral and emotional profile? Do we have an internalizing pattern of behavior? And there, symptoms like anxiety and depression fall into those internalizing patterns of behavior. We see a lot of inhibitory functions, keep things in, don't act them out, except when you're at home. We can see externalizing patterns of behavior. Those are very easy to diagnose because we're the recipient of those negative behaviors. And, the classical one is an oppositional and defiant disorder. And we see that a very high percentage of children with ADHD also present with an oppositional and defiant disorder. So not only are they absent-minded and spacey, they're ornery. They heard you, they thought about it, they decided not to do it, and that's it. That's very different from impulsivity and inattention. And then we may have atypical disorders like the autism spectrum disorders, which are disorders of quality, not of quantity. Because anxiety and depression, as we have said, anxiety is a normal emotion that we're born with. It depends on the degree and how does it impair your day. Everybody experiences attention problems. So those are quantitative disorders. Is how many of those symptoms do we have and how much do they interfere with our day-to-day functioning? Whereas qualitative disorder, stereotypical thinking, lack of theory of mind, all of those things are not typical. So these are atypical disorders. Is the how we think and how we regulate, and it impacts also our functioning on a day-to-day basis. We have health problems from chronic health concerns to frequently associated problems in the pediatric population. For example, we know that children with learning and attention problems tend to have a tenfold increase in difficulties such as encopresis and enuresis. We may see also iatrogenic problems. Am I prescribing a medication for a particular health problem that is causing either cognitive or behavioral changes on the individual? What is your sleep? What are your sleep patterns like? Do you have obstructive apnea? All of those things. And finally, we look at the environment. And in the environment, we look at home and we look at school and also at the peers. At home, we look at the parents' temperament and personality. We look at how effective they are in providing structure and consistency, the home literacy environment, how effective are their behavior management strategies. And of course, we look at the environmental stress. And stress is like cabin decompression. If you're on an airplane and there's cabin decompression and at 35,000 feet, the flight attendants will tell you someone needs your help, you put your mask on first. Because if you can't breathe, you can't help other people breathe. So it's important to assess that. We also know that chronic environmental stress will have a significant impact on the kids' neurodevelopmental progress and on brain functioning. School, teachers' temperament and personality is important. Not all of the teachers are going to get along with all of their students. The structure, the physical facility, how many students we have in the classroom, the student-to-teacher ratio. And also the curriculum demands. School have three primary goals for the students. The literacy stage, pre-K through second, third grade, depending on where you are. The general education stage from third to fourth till eighth. And in the middle of that, we get middle school, 6 teachers and a locker while the kids are hormonally challenged, which creates a tremendous challenge to executive function. And finally, we look at high school, which is the preparation for adult life. And that may include college, technical school, or going for a job. So that's what goes on. And all of that is colored by peer interactions. What are the peers doing? And from middle school on, belonging to a peer group is the most important thing. If you give me a good description of what's going on with the contributing factors, I can give you a good prescription to manage it. And that may include educational management, psychological management, medical management, and environmental management. So let's focus on the management right now of these issues. Let's start with educational management. We can provide remediation. Remediation is when we emphasize are efforts in decreasing the gap that exists between the students' weaknesses and their peers. And that includes educational therapy or teaching them executive function strategies, speech language therapy, occupational therapy, physical therapy. We can do accommodations, which is what the 504 plan does. The weaknesses emphasizes the IEP. The 504 plan gives us accommodations. And that include great technology and personal assistance. I can give you more time. I can give you, technological assistance, or I can have someone read for you. And then you have modifications, which modifications include volume and the amount of work, and that may affect the diploma requirements. So in terms of educational management, following universal design for learning principles will help a lot with the development of executive functions, with the accommodations that are needed for ADHD and to manage kids with anxiety. Because universal design for learning, it is flexible, it's inclusive learning for all. And the first thing is the why of learning, the engagement of the students, and that's giving them choices of topics and products that they can produce. It increases autonomy and motivation. So again, the social emotional component of self-direction, self-regulation, the goal setting, which also involves the neurocognitive part of executive functions, developing clear goals and allowing for progress monitoring. Varying levels of challenge and support depending on the kid's level of skill. I'm not going to have you read a 1,000-page novel if you're having reading difficulties. Connecting learning to students' interests and real-world relevance, allowing them to cooperate and reflect on the subject, discussing it with peers. So the why we're learning and to capture the kids is important. The second thing is the means of representation, the what of learning, different formats. I can give you the information, but maybe not by writing it. I can do an oral presentation. I can do a video. I can do whatever. Clarifying vocabulary, symbols, and concepts. We talk about structured literacy, where we start in a systematic and sequential way with the easiest things first, and then we begin to combine them into more complex components. So that's part of what we look at. Using graphic organizers and concept maps. These are some of the cognitive strategies that we use when we're teaching executive functions. So supporting background knowledge and comprehension, pre-teaching skills, okay? I want you to understand all of the words that you're going to read and all of the concepts that we're going to discuss, and highlighting key ideas and the patterns that they represent. And then the how of learning, allowing multiple ways to respond, the choice of format, whether it's written, oral, or digital, supporting planning, organization, and executive functions, which is critical. Again, this is all part of UDL, and providing scaffolding for skill development. And this is essential. Assistive technology tools and rubrics and examples are part of it, and ultimately encouraging self-assessment and reflection. How did I do? Most of the parents will tell you, I want my kid to be happy. I want my kid to develop confidence. Well, confidence comes from competence, and that self-assessment will help you. If you did well, your confidence will increase. Otherwise, you're delusional, and that may present a problem. Psychological management is the other management, and we have two primary approaches. We have behavior modification, which is really adult focus, and cognitive therapy, which is more child focused. Behavior modification is basically training the adults to change the way that they dealt with the child so that the child changes the way that he or she responds to the adult. And I'm talking about children here because in general terms, when we look at management of ADHD, the American Academy of Pediatrics recommends behavior management for children prior to adolescence in conjunction with stimulant medication management. But this requires training the adults. And again, there's many genetic components to ADHD, and familial predisposition is one of them. So we may have to provide a lot of training for the parents because they have not developed these skills themselves, because they may have ADHD themselves. The controls are typically external to the child, and they focus on three main things, the three baskets of antecedent, what happened before, what was the behavior like, and what were the consequences, what happened after that behavior. So those are basic elements of behavior therapy. Cognitive behavior therapy, on the other hand, focuses on how a person's thoughts, beliefs, and attitude affect their feelings and behavior. Remember when we were defining and describing anxiety, we were talking about that subjective, that perception. Well, that's where the cognitive behavior therapy focuses on. That's where what it focuses on. It's training the child to way that the way that they think, to change the way that they think about how they feel. Okay, so we're not going to change the feelings per se. We are going to change how you think about it. This is not the worst day of your life. This is not a half-empty glass of water. This is a half-full glass of water. And that changes that subjective perspective. It also allows you to develop specific strategies to address internalizing symptoms. So I can begin to work on relaxation techniques. I can do, a hierarchy of things that give me anxiety and begin to work on desensitization strategies. It allows me to increase self-control. So in order to be able to do well with behavior therapy, I have to have good self-control, which comes from our executive functions. And this is also with the helps of the adults because they reinforce that behavior. Cognitive behavior therapy is no different than what we do with explicit instruction. It provides psychoeducation. It helps the child and the family understand that the problems and behavior, what the problems and behavior symptoms are. You're not going crazy. You're having a panic attack. And these are the symptoms that you have, and this is what causes them, and that's why you feel this way. In the area where I live, there's a fantastic cognitive behavior training center. And I knew which ones of my patients were going there because they would come in and tell me, oh, no, I'm just having some somatization right now, but I'm working on my relaxation strategies. I mean, they knew the terminology as well as the therapists. So it gives you a rationale for treatment, and it reduces embarrassment and increases motivation. I had a patient that said, oh, I don't have a problem learning. It's my teacher that has the problem because she doesn't know how to teach me. So that gives you the right perspective. It's systematic. We begin to work on this in a very systematic way by teaching you first how to relax. Then we set up, okay, we're going to start with the hierarchy of fears. It's very structured. We start with the easy stuff first, and we begin to make it more and more complicated. We pair the stimulus with relaxation strategies and work on desensitization. Again, no different than what we do when we're teaching reading or writing or math. And we practice and practice and practice and practice. Again, of my patients that used to go to the Rothman Center here that used to that work with them so well on cognitive behavior therapy. My kids with social anxiety had to go to different offices in the same floor where they were and introduce themselves and talk to the receptionist. And the Rothman Center would train the people in the offices around to help when the kids would come in. So, these strategies work by identifying unhelpful or distorted thoughts. This is the worst day of my life. Everybody hates me. Evaluating and modifying thoughts. And again, is the how we think, how this deals with self-regulation, which is part of what we record executive functions for. And using evidence, look at so-and-so, they like you, and look at how good this activity was. And what are the alternative perspectives? Changing the behaviors that maintain distress through skills practice again, and developing coping strategies to work independently. Emphasizing what's happening today, not what happened in the past, so that we don't focus on just the negative thoughts. Excuse me. Medical management. Well, We can use medication or non-medical interventions in the management of anxiety and ADHD. Exercise is fantastic. It's not only good for the kids, it's good for the parents. When you're exercising, you're improving your cardiovascular system, so your kids will not kill you of that heart attack that may be impending there. You're also releasing endorphins, so you feel well. You're breathing hard, so you're not talking to anybody. You're having your own time, and it's very relaxing. Working on sleep hygiene. What do I do before I go to bed to induce sleep? Proper nutrition. There were studies during COVID that showed that proper nutrition decrease in college students, decrease symptoms of suicidality. And then healthy screen time habits. And this is critical, not only because how awake this may make you, but also because of the impact on the circadian rhythm. So this is essential for ADHD. This is essential for anxiety. For example, in sleep hygiene with anxiety, we work on relaxation strategies to induce sleep and all of that. When it comes to medication for management of ADHD, we have two types of medicines, the stimulants and the non-stimulants. And in the stimulant families, we have two main groups, the methylphenidate or the Ritalin family and the amphetamines or the Adderall family. In the non-stimulant family, we have two families, two groups too. We have the selective norepinephrine reuptake inhibitors, like Strattera or atomoxetine, and then the alpha-2 agonists, which are blood pressure medicines like clonidine and guanfacine or cataprevir that were used. The main difference between these two groups of medicines is that stimulants have a very fast onset of action, except for the patch and the medicine that you take at night so that it will kick in the morning. The non-stimulants have a very gradual onset of action, and sometimes you have to wait 2 weeks or longer to see the best effect of the medication. And you also have to titrate them so that you don't get too many side effects from them. So it may take much longer. It may take up to 2 months to see the best effect. Stimulants have a very short duration of action. They come in 4, 6, 8, 12 hours in general, maybe a little bit longer with a patch. And that the non-stimulants tend to have a much longer duration of action, 24 hours or longer. The stimulants have a dramatic effect, whereas the non-stimulants have a more subtle and gradual effect. You don't have to take stimulants every day, but you should. And you must take the non-stimulants on a daily basis to maintain the levels. Why take the stimulants every day? Because you will develop a tolerance to the side effects a lot quicker, because we have demonstrated that the kids have impairment at home and in social situations. So we just don't have ADHD on school days. We have ADHD every day of our life. In adults, it has an impact on work and productivity and social interaction. So it's important. Stimulants are a controlled substance where non-stimulants are not, so you can give refills, you can call in the prescription as opposed to requiring a written prescription. And the physicians have to take extra courses when they renew their licenses to do that. In terms of medication management of anxiety, the most frequently used medications are the SSRIs, the selective serotonin reuptake inhibitors. And in pediatrics, we recommend that they be used after cognitive behavior therapy and non-medical interventions have been tried. These are medicines like Prozac, Zoloft, Lexapro, etc. Those are the name brands that are typically used for those medicines, and they all work pretty much the same way. Finally, we go to environmental management, and we look at environmental management at home and at school. At home, promoting a home literacy and environment is important. Increasing access to books and share reading time. Share reading time is very important to promote good reading, the story format, and the verbal interaction between the parent and the child at that time. At home, promoting executive functions, again, what your parents used to do, models, scripts and routines, look at the person in the eye, say please, say thank you, shake hands, establish routines. That is very important. Let the kid play and explore and exercise. That is critical, to let them learn by experimentation. Encourage activity that allow practice to these skills. I have a 4-year-old granddaughter, and her mother is a kindergarten teacher. And she's amazing at how she guides her through different activities to explain what's going on and to help her develop those skills. This will help have the kids, transition from adult dependence into gradual independence, so they can move away from home when they're adults. The main thing is to create structure and consistency, because if you're consistent, you're predictable. And if you're predictable, you're dependable. And that's a wonderful quality to have as a parent or as a teacher. Protecting the child from chaos, violence, and chronic stress is critical. That also has a dramatic impact on the kid's development. At school, physical facility, again, part of universal design, classroom layout, seating arrangements. You want that ADHD kid close to you. You want a short leash. Why? Because you can redirect them, because you can have better control that way. Avoid typical distractions. That sometimes may be difficult. I went to a particular school out west where they had a classroom where the windows were at the top of the walls so that the kids would not be distracted. This was a school for kids with learning differences. And it was fascinating to see how they work with the kids. Again, routines, daily schedule that makes you predictable. You don't have to repeat yourself 100 times. You only have to do it 50. So that's a 50% return on investment. That's pretty good. Establishing those routines and strategies, and then teach the kids the strategies. I had the pleasure of working in a program that was probably the most positive experience of my professional career. And that was where we worked with 36 schools on the west coast of Florida, from Tampa Bay all the way down to the Everglades. And one of the strategies that they taught the kids was what they call a 3-day memory plan on how to study for tests. So even those very bright students that never needed to study, if they didn't turn in a 3-day memory plan, they either did not get 100% on the test, because that counted for 10 points, or did not get a bonus. And the kids' test performances increased dramatically on the students when they started using this strategy. So, you see the practicality of reinforcing these skills and making them meaningful to the kids' life. So with that, I'm going to conclude my presentation. We're going to have a panel discussion, on executive function and the foundation of learning in an AI world on Tuesday, March 5th from 3:30 to 4:30. That will be live. So I hope to see you all there. Take care.